So, hi friends. Now we will see part 2, that is invasive mechanical ventilation in type 2 respiratory failure in COPD. In part 1, we have seen the role of NIV. So, let's move. So, if you remember, he was a old man with chronic smoker, and he was diagnosed as acute exacerbation of COPD in type 2 respiratory failure. We have given NIV, but at last NIV was failed. So we intubate that patient and kept on mechanical ventilation. So we will see further story. So there are certain principles of invasive mechanical ventilation in COPD. So if you remember, COPD is something where hyperinflation of alveoli and there is airway bronchoconstriction. So as a normal person, for removal of a carbon dioxide, we need to keep net ventilation over 5 to 6 liter per minute. But we should remember that we have to reduce proportion of dead space ventilation. So what is dead space ventilation? Is net ventilation minus alveolar ventilation. Alveolar ventilation means the amount of gas inside the alveoli which takes part in gas exchange. While the gas which is not taking part in gas exchange is called dead space ventilation. So we have to keep low tidal volume 6 to 8 per minute 8 ml per kg. It's not R, it's kg of idle body weight. So roughly 400 to 500 ml. And we have to keep low respiratory rate. Why? As I told in first part, by increasing respiratory rate, there is increase in dead space ventilation proportion. And second thing is by keeping respiratory rate low, we can increase expiratory time. So we have to keep I ratio is 1 is to 3 or 1 is to 3, 3.5. So we have to increase expiratory phase. This is inspiratory phase. We have to increase expiratory phase. Because in COPD, as I told you, there is dynamic hyperinflation. So while expiring, airway get closed before emptying the alveoli. So we have to increase expiratory time so that patient can expire his whole alveolar gas. So in our patients, when NIV failed, the AVG was pH acidotic, PCO2 was 105, though PO2 is good. So now how to set a ventilator? So we can use either volume control or pressure control. But I prefer volume control because we have to keep watch on tidal volume because we want to prevent auto-PEEP. So how much tidal volume we are giving, we can see in volume control because we have to set. So FiO2 50%. We start with 50% and we reduce this to keep saturation of 90 to 92%. We should not keep saturation more than that. Otherwise, it will increase PCO2. PEEP 6 centimeter per water and tidal volume 8 ml per kg of idle body weight. So our patient was 60 kg, so we have kept 480 ml of tidal volume. Respiratory rate is 12 and I ratio is 1.3. So this is the setting we did our ventilation. And we have to keep watch on plateau pressure. We have to keep below 30 centimeter of water. Otherwise, it will cause barotrauma. And we have to repeat ABG after 1 hour. So we kept this setting and we have repeated ABG after 1 hour. So can you see the pH previously it was 7.2, now 7.22. PCO2 was 105, now 100. So there is very slight improvement. So we can see that there is inadequate ventilated setting because PCO2 is reducing very slowly. And more important thing is patient is still unresponsive. Patient is still drowsy, is not responding. So by this, we can say that this setting of mechanical ventilation is not sufficient to ventilate this patient. So what to do? We have to increase minute ventilation. How? Either increasing tidal volume, respiratory rate, or tidal volume. But as I told you, we should not increase respiratory rate much. Why? Because two things: the proportion of dead space ventilation will increase, and the expiratory time will get reduced. So there will be auto-PEEP. So what we should do? We should increase tidal volume. So in this patient, since SpO2 was good, so we have reduced FiO2 to 40%. Previously it was 50%. PEEP, previously it was 6 centimeter, we have reduced to 5 centimeter because there is adequate oxygenation. Tidal volume, previously we were giving 480 ml, now we have increased 550 ml. So you can see by reducing PEEP and increasing tidal volume, we can increase minute ventilation. So respiratory rate 12 is sufficient. I ratio is same. So by and large, we have increased minute ventilation, or we can use appropriate word like alveolar ventilation. So again, we have to keep PEEP less than 30, and we have to repeat AVG after 1 hour. So after 1 hour, what happened? So patient was improving initially, but now developed sudden instability of hemodynamics. Means patient got shock. His BP was reduced to below 90 by 60. Tachycardia and platelet pressure was 42, means increase. So patient, we have increased minute ventilation. After 1 hour, patient got shock, low BP. So what could be the cause? So these are the differential diagnosis. Cardiogenic shock, because these are COPD patient, old patient, they used to have cardiac comorbidity. So we don't know if there is cardiac shock. Pneumothorax, because platelet is increase. And third one is auto-PEEP. So in this patient, we have seen ventilator graph. So can you see? So this is flow volume loop. I mean time volume loop. So you can see this one expiratory phase is not touching to baseline. This is baseline. So can you see this is not touching baseline? Can you see? So it means there is auto-PEEP. So you remember, while ventilating a patient, if patient is getting sudden shock, you have to see monitor to rule out auto-PEEP. So auto-PEEP is the patient is not able to expire fully. The end At the end of end expiration, there is air inside the alveoli. This is called auto-PEEP. If there is excessive auto-PEEP, it will reduces preload, and by reducing preload, there is reduction of cardiac output. So by cardiac output reduction, it will be shock. So cause dynamic hyperinflation. So I have explained earlier that at each expiration, some air is remaining inside the alveoli, which is causing auto-PEEP and hemodynamic instability. So how to diagnose dynamic hyperinflation or auto-PEEP? So by seeing this graph, can you see this? This is not touching baseline. This is time flow time graph, and by this graph, this is flow volume loop. The flow volume loop, this is inspiratory phase, and while expiration, it is not going to baseline. So it is ending here. So this much air is auto-PEEP. So auto-PEEP is at the end of expiration, the air remaining inside the alveoli. That is called auto-PEEP. One more thing we can do expiratory hold. Means when patient is inhaled, then exhaled. So after exhalation phase or expiratory phase, at the end, we will do expiratory hold. So what will happen? The pressure inside the alveoli become equal to expiratory limb. Okay. So by expiratory hold, we can see how much auto-PEEP is there inside the alveoli. And if we try to ambulate this patient by our ambu bag, so what we will find, there is slow filling of manual ventilation bag. Ambu bag will fill slowly. That is slowly. So why this happened in our case? Means why auto PEEP developed in our case? Probably due to we have increased tidal volume, because by increasing tidal volume, so there is much air to expire. The patient not able to expire fully because tidal volume is more. Decreased PEEP, previously it was 6, we have decreased 5. There could be excessive secretions. So excessive secretion means there is airway narrowing, and by which airway is getting close before end expiration. And excessive small airway resistance due to COPD, because COPD causes bronchoconstriction and airway collapse at the end expiration. So what is dynamic hyperinflation? As I told you, when you are ventilating this patient, what will happen? At each tidal breathing, there will be retention of air inside the alveoli. Can you see? So every each breath, air will get trapped inside the lung. That is called auto-PEEP. So because of hyperdynamic inflation, auto-PEEP get increased, and at the end, it will reach up to total lung capacity. And this will cause decrease in preload and will cause shock. So what is the disadvantage? Auto-PEEP, because alveoli are hyperinflated, it will flatten the diaphragm. So what will happen? It will increase FRC and flatten the diaphragm. So what will happen? There will be increased work of breathing. Why? Because diaphragm is not able to contract because of hyperinflation. And another thing is, in this graph you can find there is insufficient trigger. Okay, so patient is not able to trigger the ventilator. Why? Normally, patient has to generate negative pressure to trigger the ventilator. Say for example, -1, -2. But if there is auto PEEP, means addition of pressure. Say for example, here is auto PEEP. So patient have to generate enough negative pressure to initiate the ventilator this much. So auto PEEP is 5, and this this one -1. The patient has to generate -6 pressure to trigger the ventilator. And COPD patient, when there is hyperinflation, not able to trigger the ventilator. So you can find there will be insufficient trigger, missed trigger in COPD patients. Another is cardiac function, abnormal cardiac function. Why? Because of increased pre-return and decreased left ventricular complex. Then it can cause barotrauma because there's hyperinflation. Alveoli is getting inflated, and then burst. So it will cause barotrauma and later on pneumothorax and pneumoperitoneum. So these are the disadvantages of auto-PEEP. So in our patient, the problem was hemodynamic unstable, means patient was in shock. So what the immediate solution? The immediate solution is just disconnect the ventilator for few seconds. Just disconnect. By disconnecting, you will feel there is gush of air coming out from the lungs. So if after disconnecting the ventilator, if shock resolved, it means shock was due to auto PEEP. If shock persists even after disconnecting the ventilator, means the shock probably due to cardiac. You understand? So if improve due to auto PEEP, if not improving, we need to rule out cardiogenic shock. So how to reduce auto PEEP? In emergency condition, you can disconnect. But in chronic condition, when auto-PEEP is developing slowly, then what can you do to decrease the PEEP, auto-PEEP? So we have to increase I ratio, and we have to increase expiratory phase, expiratory phase, because patient has to expire in expiratory phase only. So patient not able to expire fully. That's why this retention of air inside the lung. It's called auto-PEEP. So if we increase expiratory phase, the auto-PEEP problem can be solved. Now question is how to increase I ratio. So there are two things we can do. Either we can reduce tidal volume, or we can reduce respiratory rate, or what we can do, we can increase inspiratory flow rate. Means we can shorten the inspiratory phase. This is inspiratory phase. This is expiratory phase. If we shorten this inspiratory phase, then we can increase expiratory phase. So how to decrease this inspiratory phase? By increasing inspiratory flow rate. Means air is going very fast inside the lung. So less time needed for inspiration. So by this we can reduce inspiratory phase and increase I ratio. Another thing is we can apply external PEEP. As I told you, the internal PEEP is there inside the alveoli here, because while expiration, this airway is getting close. So patient not able to expire fully. But external PEEP, what we are giving by ventilator, is giving here. So what will happen if we are giving PEEP of, say for example, 5 centimeter? So it will keep open at the end of expiration. Auto PEEP is, say for example, 7 centimeter, and we are giving pressure of 5. So at the end of expiration, airway pressure is 5, so open. So the auto PEEP will get reduced to 2 centimeter, because 7 centimeter here is 5 centimeter here. So only 2 centimeter will remain. So this is how external PEEP can reduce auto PEEP. Now we can reduce airway flow resistance by bronchodilator and steroid. Because case of COPD, we have to give bronchodilator and succession of secretions. Because in COPD patients, there are a lot of secretions which used to obstruct airway and not letting out the air out. So we have to do frequent suctioning. If there is thick suctioning, we have to use HME filter. What is full form of HME? Heat and moisture exchanger. Our airways having enough heat and moisture, but it is used to lost by ventilator. So if we put this HME filter, so our heat and moisture will retain inside the airway, because it is not letting out the heat and moisture out of the airway. So where we should attach? We should attach at the distal end of Y junction, between endotracheal tube and this Y junction. So here we have to attach. In NIV also we can attach this HME filter. But you should remember there should be two limbs separately, inspiratory and expiratory. We cannot use in portable NIV. Keep remember, we cannot use in portable NIV where there is only single tubing, inspiratory and expiratory. So in that case, we cannot use HME filter. Nebulization. So in COPD, there is bronchoconstriction. We have to nebulize that patient. So where we should attach? We should attach distal end of HME filter here. After HME, between endotracheal tube and HME filter, we should use nebulizer. Another thing is, if still there is high airway resistance, we can reduce airway resistance by cut short ET tube, because the length of ET tube or ventilator circuit will increase the resistance. So we have to keep small circuit and we have to do frequent suctioning because secretions also increases airway resistance. So coming to our patient, since auto-PEEP was there, we have reduced, we have increased PEEP 6. Previously it was 6, we have reduced to 5, now again increased 6 because of auto-PEEP. Tidal volume, we have reduced little bit. We were giving 550, now we are giving 500. Respiratory rate is same. I ratio we have increased. Previously we were giving 1.3, now we have increased 1.35. So by this method, we can reduce auto-PEEP. We also added HME filter, frequent suctioning, nebulization. We have cut short ET tube to prevent resistance, giving antibiotic according to culture. And remember, we have to give adequate nutrition because these patients are lean and thin and catabolic state. So we have to give enough protein, enough nutrition. Otherwise, they will go for critical illness, neuropathy, and myopathy. Then very difficult to wean these patients. So in our patient, it's improved 2 days. In 2 days, ABG become stable, vital stable. Patient was conscious oriented. Then next, what to do? So we have to start weaning by pressure support ventilation. So in our patient, we were giving FI to 25%, PEEP reduced to 6, or we are giving same PEEP, pressure support of 10 centimeter, and patient doing well on this setting. So patient was doing well on pressure support ventilation, means patient was taking his breath, the ventilator was supporting only, like in NIV. So say for example, patient is taking his 250 ml and ventilator supporting 10 centimeter of water, means another 250 ml to become 500 ml. So this is pressure support ventilation. So what is other problem in case of COPD? So other problem is weaning difficulty because these patients are chronic patients. They used to have chronic hyperinflation and emphysema. So these patients are difficult to wean patient. So we have given TP trial, but patient was not able to tolerate. Why? Because patient not able to take enough tidal volume by narrowed ET2. Because patient needs around 500 ml, but because of narrow endotracheal tube, patient not able to take enough tidal volume. So what will happen? Patient will have increased work of breathing because patient not able to get enough tidal volume. So what will happen? Because of work of breathing, patient will go in muscle fatigue and increase CO. This was weaning failure. Then we have tried weaning by pressure support ventilation. But the problem is we were not able to reduce pressure support below 10 centimeter. Why? Because once we were reducing pressure, patient was getting hypoventilation because patient was not getting enough tidal volume for ventilation. So patient was getting hypoventilation and increased PCO2. So this is also a weaning failure. So we were not able to give TP trial and we were not able to wean with pressure support ventilation also. So what to do next? So this type of patient, literature says we can extubate this patient and keep on NIV. Don't wait for weaning. We have to extubate and keep on NIV. But patients should qualify other weaning criteria, like patient should be conscious, vital stable, and ABG stable. All these things it should meet. Finally, our patient was extubated, kept on NIV, and discharged later on. Don't forget, ask patient to quit smoking, vaccinate the patient with pneumococcal influenza vaccine, and ask patient for regular COPD treatment. Because every exacerbation reduces lung function and increase morbidity and mortality. So to prevent further exacerbation, please do these three things: quit smoking, vaccination, and regular COPD treatment. So that's all. Thank you very much. If you have query, please send me on comment box. Meet you soon with another video. Thank you very much.